actually received birthing services primarily with midwives, but it would also be possible with family physicians as well. Maternity care. So this is our birth room here. So if you want to come in here, so we have a birth bed that was made by a local carpenter.
The main message was the tremendous challenge we have in providing services and meeting the needs of people and communities in the remote and northern parts of Canada. In the video about midwifery and repatriation of births in Fort Smith, we learned about a wonderful service that probably provides birthing services once or twice a month in that community. So the births are not frequent, but they're important events. And so how do you make sure that you maintain quality in the face of events which don't happen all that often?
About 75% of women are considered appropriate to birth in the community. From those, 3/4 birthed in the community and 1/4 decided to go elsewhere, and women do have a choice.
We learned lots about the benefits to community when community has access to services over a period of time, and how that develops confidence in community members and in the practitioners themselves.
Interesting here is the premature birth rate of the program. You can see in Fort Smith significantly lower than territorial or national rates.
I think probably the most basic step that needs to be taken is a policy and value decision, which is that we ought not to accept that individuals living in rural and remote Canada should have less access than the rest of Canadians to needed medical services.
More than 100 communities in Canada, rural Canada, have lost local birthing services in the last 2 decades. And there's a real resurgence of interest into either preserving what's left in small communities in north and rural Canada, or even repatriating birth to communities that have lost it.
Once we accept that every Canadian should have access, even if they're in hard-to-reach places, then there are a whole set of innovations and policy decisions which flow from that. So that equity decision, I think, is the most important one.
Some places it's been the community that has said, we want birth back, and we're going to go out and hire and find midwives to come and provide that and train local people. That's what happened in Nunavik. In Fort Smith, there was a committed provider and then 2 committed providers who simply worked with the community and said, we can do this, and now they have a program that's working well and they're proud of. But other communities, whether it's the community driving it, family physicians driving it, midwives driving it, health authorities driving it, I think it's important that this gets recognized as a possibility.
I think often the counter-argument is, well, it's just not practical. You know, it's just not practical to be able to supply these sorts of services in remote areas. And yet we learned today that in fact it can be very practical if you think in different ways.
Everybody obviously is concerned about the safety of doing maternity care in a place without an OR. But here it's been done with open eyes, with full disclosure to women about what that means, both the benefits to them, their families, and their communities, as well as the potential risks, with a very careful approach to risk selection and risk stratification about who's appropriate for community birth. And you know, the numbers are still relatively low, but you can see from them that the wheels aren't falling off. This is not a particularly dangerous thing. This is within the realm of accepted risk if that's what a woman and her family want to do. So as a model of those 2 things, both the logistics and the acceptable level of safety, I think this hopefully can provide a model for other communities that would like to borrow it.
Let's not let overarching ideas of scopes of practice or funding or other top-level decisions get in the way of creative local solutions that can be made to work in particular community circumstances.